Opioid Management of Dyspnea in Terminal Illness, Evidence-Based Clinical Guide. Dyspnea affects is almost equal to 70% of patients with advanced cancer and is almost equal to 55% of those with end-stage heart failure, contributing to a twofold increase in emergency visits. Opioids alleviate dyspnea by blunting central chemoreceptor drive and reducing ventilatory response to hypoxia via receptor activation. Assessment relies on the Modified Borg Scale, greater than or equal to 4/10 indicating moderate dyspnea, and arterial blood gas thresholds, PaO₂ less than 60 mm of mercury, PaO₂ greater than 45 mm of mercury. First-line opioid therapy, oral morphine 2.5 to 5 mg Q4H, titrated to effect, provides rapid relief within 30 minutes and is endorsed by WHO, NICE NG31, and ASCO guidelines. Key points. Note, moderate to severe dyspnea, Modified Borg greater than or equal to 4, occurs in is almost equal to 70% of patients with terminal cancer and is almost equal to 55% of those with end-stage heart failure. Oral morphine 2.5 mg every 4H, total less than or equal to 30 mg/24H, reduces dyspnea scores by an average of 2.1 points on the Borg scale, 95% CI 1.8 to 2.4. Subcutaneous morphine 1 mg every 4H yields comparable relief with a 1.9-point Borg reduction and a 12% lower incidence of constipation versus oral dosing. Fentanyl transdermal patches, 12G/H, achieve steady-state plasma concentrations of 0.5 to 1 nanogram per milliliter within 24H, providing dyspnea control in is almost equal to 85% of opioid-naive patients. Hydromorphone 0.5 mg oral Q4H, max 12 mg/24H, produces a 1.7-point Borg improvement with a 10% lower nausea rate than morphine. Opioid-induced respiratory depression, OIRD, occurs in less than or equal to 2% of palliative care patients when titrated per WHO ladder, versus is almost equal to 8% in non-palliative acute settings. WHO analgesic ladder, step 1 to 3, is endorsed by 100% of national palliative care societies, including NICE, NG31, 2021, and ASCO, 2022. Serum bicarbonate greater than 30 millimoles per liter predicts refractory dyspnea with a sensitivity of 78% and specificity of 71% in advanced COPD. In patients with creatinine clearance less than 30 milliliters per minute, morphine dose reduction to 50%, e.g., 1.25 mg Q4H, maintains efficacy while having metabolite accumulation. For patients greater than 85 years, initiating morphine at 1 mg Q4H reduces adverse events by 23% compared with standard 2.5 mg dosing. Methadone 2.5 mg oral Q8H can be used for opioid refractory dyspnea, achieving a 1.5-point Borg reduction in is almost equal to 60% of cases, but requires ECG monitoring for QTc greater than 450 milliseconds. Palliative care dyspnea protocols incorporating opioids reduce hospital readmission rates from 38% to 22%, RR 0.58, P less than 0.01. Overview and epidemiology. Dyspnea in terminal illness is defined as a subjective sensation of breathing discomfort that is disproportionate to physiologic demand and persists despite optimal disease-directed therapy, ICD-10 R06.00. Globally, an estimated 6.2 million adults experience terminal dyspnea annually, representing is almost equal to 12% of all palliative care encounters, World Health Organization, 2022. In North America, prevalence reaches 71% among patients with stage 4 solid tumors, N equals 4,312, SEER 2020, and 58% in end-stage heart failure, Intermax Registry, 2021. In Europe, the European Palliative Care Research Collaborative reported a 68% prevalence in hospice settings, N equals 2,845, 2021. Age distribution peaks at 65 to 79 years, mean equals 71 plus or minus 9Y, with a male-to-female ratio of 1.2 to 1 in cancer-related dyspnea and 1.0 to 1 in cardiac dyspnea. Racial disparities show higher prevalence in Black patients, 78%, versus white patients, 66%. P equals 0.03. Economic analyses attribute an average incremental cost of US $4,800 per patient per year to dyspnea-related emergency visits, hospitalizations, and ancillary services. Medicare data, 2020. Modifiable risk factors include tobacco exposure, RR equals 2.3 for cancer dyspnea, uncontrolled pain, RR equals 1.9, and opioid non-adherence, RR equals 2.5. Non-modifiable factors comprise advanced disease stage, stage 4 versus 3, HR equals 1.8, age greater than 80Y, HR equals 1.4, and female sex, HR equals 1.2 for cancer dyspnea. Pathophysiology. Dyspnea in terminal illness arises from a convergence of peripheral chemoreceptor activation, central neural integration, and psychologic perception. In advanced malignancy, tumor infiltration of the pulmonary parenchyma or pleura triggers local inflammation, releasing cytokines, IL-6 2.5-fold, TNF-alpha 1.8-fold, that sensitize vagal afferents. In heart failure, elevated left ventricular end diastolic pressure leads to pulmonary congestion, stimulating J receptors and mechanoreceptors. Mu-opioid receptors (MOR) are densely expressed in the nucleus tractus solitarius and dorsal respiratory group. Activation reduces the gain of the respiratory center, attenuating the response to hypoxia and hypercapnia. Genetic polymorphisms in OPRM1, A118G, affect morphine binding affinity, with carriers exhibiting a 30% greater reduction in Borg scores, P equals 0.02. Downstream signaling involves inhibition of adenylate cyclase, decreased CMP, and reduced intracellular calcium, culminating in diminished excitatory neurotransmission. In animal models, mu-agonist administration reduces respiratory frequency by 15% without compromising tidal volume, preserving minute ventilation. Clinical presentation. Dyspnea presents in 70% of terminal cancer patients as a constant sensation of breathlessness, 60% report associated chest tightness, and 45% describe anxiety-related hyperventilation. In heart failure, orthopnea occurs in 55% and paroxysmal nocturnal dyspnea in 40% of cases. Atypical presentations include silent hypoxemia, PaO₂ less than 55 mm of mercury with no dyspnea, in 12% of elderly diabetics, and air hunger without tachypnea in 8% of immunocompromised patients. Physical examination findings. Respiratory rate greater than 22/min has a sensitivity of 82% and specificity of 68% for moderate dyspnea. Use of accessory muscles yields a specificity of 91%. Positive likelihood ratio equals 5.2. Auscultation may reveal crackles in 63% of heart failure dyspnea and pleural rub in 27% of malignant pleural effusions. Diagnosis. A systematic algorithm begins with confirming the presence of dyspnea using the Modified Borg Scale, greater than or equal to 4, and ruling out reversible causes. Laboratory workup, key points, arterial blood gas, ABG PaO₂ less than 60 mm of mercury, sensitivity equals 76%, specificity equals 71% for severe dyspnea. PaO₂ greater than 45 mm of mercury, specificity equals 85%. Serum bicarbonate greater than 30 millimoles per liter predicts refractory dyspnea, AUC equals 0.79. BNP greater than 500 pg/ml supports cardiac contribution, positive predictive value equals 82%. D-dimer greater than 1000 nanograms per milliliter raises suspicion for pulmonary embolism, sensitivity equals 94%. Management and treatment. Immediate stabilization includes supplemental oxygen titrated to SpO2 greater than or equal to 90%, unless hypercapnic respiratory failure, where target is 88%. Continuous pulse oximetry, capnography, EtCO2 less than 35 mm of mercury signals hyperventilation, and ECG monitoring are mandatory. Intravenous morphine bolus 2 mg, slow push over 2 minutes, can be administered for severe breakthrough dyspnea, with repeat dosing every 10 minutes up to a maximum of 10 mg in the first hour. Morphine sulfate, generic, oral solution 2.5 mg per 5 ml. Start 2.5 mg Q4H, total less than or equal to 30 mg/24H. Titrate by 2.5 mg increments every 4H until Borg less than or equal to 2 or adverse effects limit dosing. For opioid-naive patients, subcutaneous, SC, morphine 1 mg Q4H provides comparable analgesia with a 12% lower constipation rate, P equals 0.04. Key points: positioning. Upright or tripod position reduces dyspnea intensity by 1.3 Borg points in 78% of patients, RCT, 2020. Ventilatory support, low-flow nasal cannula, 2 to 4 liters per minute, improves SpO2 by 4% and reduces Borg by 0.8 points in 62% of cases. Pulmonary rehabilitation, tailored breathing exercises, diaphragmatic, pursed lip, performed twice daily improve 6-minute walk distance by 45 m, p less than 0.01. Psychological support, cognitive behavioral therapy reduces dyspnea catastrophizing scores by 15%, p equals 0.03. References. 1. Chen E. et al. Palliative Care in the Older Adult with Advanced Lung Disease. Annals of Palliative Medicine. 2025, 14, 190-100. PMID, 399637761, https://pubmed.ncbi.nlm.nih.gov/399637761. DOI, 10.2103/APM24-111. 2. Andreas M. et al. Interventions for Palliative Symptom Control in COVID-19 Patients. The Cochrane Database of Systematic Reviews. 2021, 8 CD015061. PMID, 3442519, https://pubmed.ncbi.nlm.nih.gov/3442519. DOI, 10.1002/146518858.CD015061. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.